It's really just the exercise.
Looks great.
Oh, yeah.
All right, good morning, everyone. I'm Bryce Haynes, one of the PGY3s, for those of you that haven't met yet, and I'll be talking to you about sharps and needle stick injuries and what orthopedic surgeons need to know about these. I have no relevant disclosures for today. Just a quick overview. It looks like, so we'll be talking about background first, response to one of these events, and then finally prevention. For background, CDC defines exposure as when you sustain a needle stick or a cut from a contaminated sharp object, and it does go through your skin. There's an increased risk of transmission with deep injuries, injuries that draw blood, when you're stuck with a large gauge hollow bore needle, particularly after it's been intravenously used in a patient, and then when the patient has a high viral load. And then a mucocutaneous contact is when you have blood or body fluid that contacts your eyes, mouth, nose, or broken skin. It's estimated that 385,000 healthcare workers per year sustain these injuries, although this number is likely pretty low due to underreporting. In this AAOS survey done in 1992, all the orthopedic surgeons at the annual AAOS meeting were surveyed, and 40% of them said that they had had a percutaneous injury with a sharp within the past month. As far as the diseases, these are the ones we always hear about and the ones that are the most important to think about after you get stuck. HIV, hepatitis B, and hepatitis C. Rates of infection, if you do have a percutaneous injury, your chance of being infected from a needle stick is about 0.3%. For hepatitis B, it's anywhere from 6 to 30%, depending on the antigens and titer of Hep B in the patient, and then hepatitis C is about 1.8. For mucocutaneous exposure, we only really have data on HIV, and it's reported to be 0.09%. I think other things to think about is that pretty much any infectious disease can be spread from blood-to-blood contact, or a lot of them can be. There are several case reports in the literature of necrotizing fasciitis from group A strep being spread from patient to surgeon or patient to healthcare worker from needle stick. In this particular one, a chief resident placed a central line in a patient with neck fasc, accidentally nicked the back of her 5th MCP joint, and ended up in the ICU, required multiple debridements, and ultimately a muscle flap to close a wound defect. And then also at Vanderbilt University, there we go. Dr. Obremski is an orthopedic trauma surgeon there, and during a hip disarticulation done back in the 2000s, he was doing a hip disarticulation, a 55-year-old patient who had neck fasc. Patient later died several days later, but during the case, he had a couple events. One, he was stuck with a bovie during the case in his arm, and then two, his socks, he wasn't wearing protective shoe covers, and he ended up getting his socks and shoes soaked with body fluids and blood from the patients. About 8 days later, he went on to become really sick and was admitted to the hospital with necrotizing fasciitis of his left leg. He required multiple INDs, was intubated, and eventually came through. But I think this just goes to show the importance of standard precautions in the OR. It's suspected that due to his feet and socks getting soaked with blood from the patient, that it did, through his athlete's foot, cause this to happen. Just a little bit of brief history. So in 1971, the Occupational Health and Safety Administration was established. President Nixon signed the law into act several years before that. In 1991, they published the bloodborne pathogen standard. This was largely in response to the AIDS crisis that was going on at that time to protect healthcare workers. Through it, they just go over the fact that you need engineering or work controls to minimize your exposure, guidelines for PPE. You have to have a written exposure plan at your hospital. They do solicit input from non-managerial employees yearly to get feedback on ways to improve the system. They have a sharps injury log, and then there's also annual training like we do yearly, the ACE bloodborne pathogens. This will be your early reminder that it's due in 254 days. And then in 2000, there were some minor updates in the Needlestick Safety and Prevention Act, mostly involving definitions. So in orthopedic surgeons, your risk is estimated to be from survey 80 to 90% over 10 years, and that's when you're attending out in practice. For trainees, it's pretty high. Orthopedic residents are 12 times higher than EM residents to get stuck, and at the highest on the list in this study. And then 90% of them have a needle stick injury or sharps injury by graduation, and most of them have greater than 4 exposures. Yeah, I think in our field, we deal with a lot of sharp instruments, fractured bones, K-wire, saw blades, clamps, bone hooks, the list goes on. And our fingers are often in close proximity to sharp objects in the wounds. We also rely on tactile feedback, and in the South, we do operate in deep cavities and big patients with poor visualization. So increased care is needed in those situations. All that being said, suturing still in the majority of studies is shown to be the most likely time to sustain one of these injuries. Greater than 30% of the time, healthcare workers and surgeons are stuck during wound closure. K-wires was second, scalpel third, bone fragments fourth, and then drill, broken implant, screw all pretty low. You can also see that the most likely injured spot on a surgeon is the index finger of either hand, with the left index finger being most commonly injured. When asked surgeons why they felt like they got stuck, this was a surgery done on residents, and they felt that 50% of the time their injury was due to feeling rushed. Other common reasons were fatigue, lack of skill in 12%, lack of assistance, and then just overall, they felt like it was an unpreventable event. Following the injury, surgeons are not great about taking care of themselves and addressing the situation. Only 58% in this study stopped to wash the wound. 41% just kept working. Only 32% had the patient tested, and then 30% had their own blood tested. And there's an extremely low reporting rate. Multiple studies show consistently less than 50% of these injuries are reported. This is from respondent number 39 in the above study out of Toronto. He said, "I have sustained so many needle stick injuries during my residency that I no longer pursue this. This is the case for many surgical residents. I believe needle sticks are commonplace, especially at some other sites where retractors are used that expose their sharp tips in the operative field. When staff backhand scalpels while they work, where the scrub nurse insists on keeping the sharp cautery always pointed right at your elbow, I get stabbed with that a lot. I can't be on prophylaxis all the time. And as an intern, it was indicated to me that if you make a fuss over every needle poke, you will be seen as a safety hazard. So you should just accept that as a risk at the job." And I think, while this is maybe a little bit of an over-exaggeration, there are a lot of people that do feel this way, that aren't too worried about needle sticks, that do just keep going. And I think creating a culture where we do take them seriously puts us at least risk and is best for trainees and surgeons. Regarding low reporting, just the main barriers, most common barriers were the time it takes to report, low suspicion of the patient being infected, the stigma, like in the previous slide, and then people not wanting to know results and having anxiety. So response after sharps exposure, immediate next steps are take your gloves off, examine the area, wash it with soap and water. You don't need to use alcohol or a diluted bleach solution. Next step would be to call the injury helpline at 704-355-SAFE. I did, during preparing for this talk, call them. It connects you with an operator who gets you in touch with an infectious disease nurse who is extremely helpful, can walk you through any step, and can help you find this report of injury or illness if you have trouble online, which is the next step, is to complete that. And then finally, always test the patient if you're concerned or you have an actual injury where a contaminated instrument punctures your skin. This is just showing you kind of the steps. You can get a People Connect, HR forms, and then under R, you can find the report of occupational injury and illness. But I'm sure people will forget, so you can just call the number and they will help you get there. For the Needlestick hotline, as I mentioned earlier, it connects you with an infectious disease nurse. They are available 24/7. and are super helpful. They walk you through the next steps. They can prescribe you right then and there post-exposure prophylaxis, and they will follow up with you the next day and the following days and help you figure out everything you need to figure out to take care of you. Again, they're extremely helpful. They're your advocate, and they're great to talk with. Lab tests. Hopefully you'll never order these. Hopefully an anesthesiologist or nurse in the OR or the unit leader will order these, but in case you have to, the order is right here. It's IP, which is for inpatient exposure lab orders. This automatically gets you a HBV surface antigen, a hepatitis C antibody screen, and then a rapid HIV antibody screen, which is usually done within 30 minutes to 2 hours. If the patient has known infection, it actually just goes ahead and you can select just to know their titer, so you can know how infectious that patient is, and the order set will help you do that. It's fairly straightforward and shouldn't be any problem. This is if, in worst case scenario, you had to put it in yourself. Also important to know is in North Carolina and South Carolina, no consent is needed prior to drawing these labs on a patient. And there's no charge to the patient. All this is covered by Atrium, and you get your baseline labs. You're supposed to get them within 72 hours after an exposure. If you are stuck with a patient with HIV and you do undergo post-exposure prophylaxis, I think it's just important to know what that looks like. It's a 3-drug regimen with these two pills, Truvada and raltegravir. It's 85 to 90% effective when started within 24 hours after a stick or an injury, and it goes down after that, especially after 48 hours. So it's super important to get started on that right away. It only consists of 28 days of treatment, and that again is covered. And if you are unsure the patient's status and their labs are delayed, you can always just call them. They can send it into the Atrium pharmacy, and you can pick it up and discontinue it if the patient's labs come back negative. But if you have a high-risk patient and you don't have the final blood studies back, you can't do that. And then as far as treatment goes, say you do get treated, as long as your labs look good at 4 months, that's your final checkup, and you're done after that. For hepatitis B, nowadays, this used to be a big problem because the infection rate is so high from percutaneous injury, up to 30%. All healthcare workers nowadays are required to be vaccinated or sign a waiver afterwards. If you do have a vaccine and you do have a positive titer, you really have very little to worry about. If your titer is low or you're not vaccinated, they can give you Hep B immunoglobulin, which is also very effective. And then for hepatitis C, we don't have a vaccine, as you all know, for prophylaxis. But nowadays, Harvoni has a cure rate of 94 to 99%, and hepatitis C type 1 or 1 genome, which is the most common form of the disease. And there's an article in the Journal of Hand Surgery called First Hand, written by Charles McDowell, a hand surgeon in Virginia. He talks about having a needle stick on a patient while closing the wound, and 2 weeks later, he developed malaise, fevers, and jaundice. Luckily, he had reported that. So he got quick treatment back then. The treatment had a lot more side effects before Harvoni was out there. He went through 24 weeks. He was eventually cured, but there was only a 40% success rate back then. And so he just tells his story and how he wishes he would have been paying better attention back then, but he was glad that he did reach out and report the event. And then the cost was, this is the cost for Harvoni nowadays, is about $95,000 for 12 weeks. Again, that is covered, but just so you know. Preventing needle sticks, we're trained on this every year, so you guys know the majority of it. You maintain universal precautions and assume that all patients are potentially infectious. Wash your hands frequently. Avoid recapping needles when possible. You can also use blunt retractors instead of sharp ones. And then have increased awareness during wound closure, especially if there are 2 surgeons closing. Split up the wound and communicate with each other so to avoid needle sticks. And then also double gloving. There have been several biomechanical studies which show that puncture resistance is reduced or is greater with 2 gloves, giving you more protection. But you do get some decreased tactile feedback is the drawback. When looking at surgeons and their compliance rates, orthopedic surgeons typically do pretty well with this. At this institution in, I believe, Toronto, there was a 92% compliance rate with orthopedic surgeons, and the average for all specialties was 66%. These are some extra pearls from Dr. Ward, who is our safety guru here at Atrium, North Carolina. First is no hand-to-hand transfers. Always place a sharp down and use the safe pass zone, which is something we always talk about in the preoperative timeout. Surgeon can announce sharp up and sharp down when handling objects. Never cut or drill towards yourself. And then in the picture here on the right, I don't know if you can see it well, but he's covered a K-wire with a needle cover in order to prevent sticks, which can happen. And then if you do have to recover if you do need a needle and you want to recap it, you can recover it by using the push away technique, kind of on the bottom right there, which is the safest way to do it. So that's all I have. In conclusion, Sharps injuries are extremely common and underreported, so they're likely more than we see in the stats. Transmissions rate is extremely low. There have actually been no reported transmissions at Atrium, but there are some in the literature, and is a very serious consequence when it does happen. I have the hotline number again listed there. And if you do get stuck and do take prophylaxis, you're best off taking it and starting it within 24 hours. And then always, just keep safety in mind when you're in the OR, and have our training those below you. I want to thank Dr. Ward, Dr. Lewis, and Dr. Phelps. Here are my references. If anybody has any questions or comments, I'm taking them. Dr. Ward.
Yeah, that was a great talk. I've been a champion of this for several decades. I've been practice longer than anybody else. Probably stuck more often. I think for me, I used to get stuck probably twice a year routinely, so I probably had at least 60 sticks in my career. And I think it's when I'm rushed, when I'm suturing. Most commonly, it's two people moving their hands at the same time on the field. And if you have loops on, your field of vision is narrow. You can't see where your hands are. And I think announcing sharp up, sharp down, and when your sharp is up, everybody else in the field should freeze. Nobody else should be moving their hands unless there's something really bad going on. So if you freeze all the other players in the room, you'll really avoid a lot of these sharp injuries. I would also check your hepatitis B titers, just because if you do get stuck and you're not immunized, you could be at a big worry. One of my former patient partners died, unfortunately, of this hepatitis B acquired from the patient stick years and years ago, back before immunization was available. So it is a very real problem. I think if you slow down, you're mindful of where the sharps are, and you don't rush, I think you can avoid a lot of these problems. And if you talk to anybody who's been through some of these treatments or exposures, it makes you sick, you lose time out of work, you can get depressed with a lot of these medicines. It's really something you should avoid.
Dr. Pat.
Thanks, Bryce. I think that just resident and surgeon safety, this is a really important talk. The orthopedic resident study referenced, some of your predecessors here participated in that. So it was a study that we authored. We looked at a bunch of different safety things, but we did that survey. The biggest cautionary note from that survey of orthopedic residents was over 40% not reporting them.
Yeah.
And I think that that's consistent with a lot of the other specialties. I do think, having talked to some of the other authors of other institutions when we were writing that up, a lot of institutions, it's more difficult the process is more difficult than it is here. It's not that big a deal. When you get stuck in surgery, A, deal with the acute stuff, but B, they can put in the order and draw the labs while the patient's still asleep. They can get all that in the process. So, don't not do that. It's really important. But it's also scary. I mean, my second week of fellowship, I got hit with one of the large hemovac needles. If you've ever seen that, they're like harpoons in a Hep C patient. That was all the things that Dr. Ward just mentioned were wrong. Multiple people working in the wound. The attending actually did it to me. And he was coming from the other side and just jamming it through. And so they're 98% avoidable with proper techniques. And I think you pointed out a lot of those here. So I think it's a good thing if anybody ever gets stuck and has any barrier to reporting it, any barrier to the process. I'll volunteer myself, call me and we'll figure it out. Because I think that we should have 100% reporting of that process to make sure that you're all safe. Thank you though.
All right, thanks.
Thanks everyone.
Oh, real quick, I think that's great because we're about to have a bunch of medical students running around here too, even more than we have. And as you saw in your literature, most of your exposures are in the early part of your career, although as Dr. Ward said, we all get exposures throughout the career, but to understand that pathway, I think is important because it's much easier than any institution where I've ever been, where you had to actually leave the operating room immediately and get your blood drawn. And that's why most of us got into the habit of non-reporting.
Yeah, it's definitely streamlined. The nurses who you talk with are truly phenomenal. And it's pretty easy. Just quick phone call and computer form you can do in between cases, and that's it. So
Quick reminder, Dr. Loeffler is going to be talking next week about nerve injuries and mitigation strategies. That's going to really focus on almost every subspecialty of orthopedics. So I think there'll be a little bit of everything for everyone. So look forward to that.